I am a pediatrician by training, and so I'm going to have a little bit different view than most people here that live in the world of data. But we've been doing some exciting things in Kentucky, and I'll just let you know about some of them. First, kind of to set the stage, the World Health Organization defines health as a state of complete physical, mental, social well-being, not merely the absence of disease. So just keep that in mind when you're starting to look at your data and looking at more than just health data. Looking at America's health rankings, this is a great site to go to get an overall look at a state's health outcomes. They look at 30 different metrics from different subsets, and then they put it together for one health outcome. So anybody know what Kentucky's overall health ranking is? 49. That's right. Actually, it's 45. Thank you. And these are some of the, let's see, can I press this? What happens? These are just a few of the 30 metrics that they look at, divided up into their different groupings. So you have the behaviors, community, policy, and then clinical care down here at the bottom. Putting all those 30 things together, they look at a bunch of different outcomes, and these are just a few. As mentioned earlier, today Kentucky ranks 50th in cancer deaths. In premature deaths, we're at 47, and then frequent mental distress and frequent physical distress, we're at 48 for both of those. We do have some that are a little better, and that brings us up to 45. Looking at that ranking over the last 20 or so years, it really hasn't changed much. And in fact, it's getting, if you can see the trend line, it's getting a little bit worse over time. And this is disturbing because there's a lot of really good people, that's working on this, and they've been working on it for 20 years, and we haven't made any difference. And so I would suggest that the difference is data. You have to start using data to look at what's going on, and data to try and make some changes in policies. So at the Cabinet for Health and Family Services, we have a bunch of different divisions. In there we have Medicaid, which I've put at the top because I am part of Medicaid. We have public health. We have children with special health care needs. We have behavioral health. So we're a huge, huge cabinet. But what I've put right here in the center is the Office for Health Data and Analytics, because that's our group that helps us look at all of the data, all the different data sources coming into the cabinet, and helps us analyze that data. And I'm lucky today because I not only have the executive director for the Office for Health Data Analytics, Robert Puck, which is over here in the audience, but I also have our Chief Analytics Officer, Mike Schutz. But it really is the heart, I think, the heart of our cabinet. And just a little bit about Medicaid in case there's people in other walks of life. Medicaid provides coverage for 75 million people, over 75 million people nationally, and those are low-income adults, children, pregnant women, elderly, and people with disabilities. It is actually a state-federal partnership, so the federal government provides the majority of the funds. States also have funds involved, but we administer the programs. And in contrast with Medicare, that's actually a federal insurance program for individuals over 65, and it's administered or run by the federal government. So Medicare is the same in every state. So each Medicaid program is different. So if you've seen one Medicaid program, you've seen one Medicaid program. You might have all fee-for-service, you might have managed care, it might be a combination of the two. You could have one managed care company or 12 managed care companies. It may have been an expanded program through ACA or not expanded. And then, of course, the services and the medications are different, the coverage in different states. So that's an advantage to the Medicare programs because it allows each state to tailor the needs of their population individually for the population. because Kentucky's needs might be different from Hawaii's needs. But it makes things difficult when you're trying to look at data across state lines. So in Kentucky, we have expanded Medicaid as part of the ACA. Currently, there's 5 MCOs, or managed care organizations, and that serve really the majority of our population. And then we have a small fee-for-service population. We have about 1.3 million people covered by Kentucky Medicaid, which is about 30% of our residents. And we cover close to 50% of the births in Kentucky. So what I want to talk about is state university partnerships, Medicaid outcomes distributed research networks, and linking health data with other data sources. Has anyone heard about state university partnerships? 1, 2, 3. Okay, great, that's great. Well, this is actually a wonderful thing that you can do with the research universities in your state. So it's a collaboration between Medicaid and universities, state universities. You partner with the universities really to extend the capacity of Medicaid to conduct research and to support the evaluation of programmatic decisions and policy development. And in Kentucky, our state university partnership program is part of the Cabinet for Health and Family Services. It's really simple to participate. The research that the universities are looking at really has to align with Department of Medicaid Services strategies and with our needs, so we need to get something out of it. The projects are approved by the Cabinet and by Medicaid for funding, and a little caveat, you can't match federal money to fund the project. So if they've already got some federal dollars in their research project, you can't match it with our program. So basically, it's leveraging the federal Medicaid money to provide a cost share to support research. And the dollars, the CMS will draw down those dollars from the federal share, bring that to the table, and the states match the state share. So it's great. It helps fund research in the universities, and they help analyze our data and research with our data. So currently we have 9 active research partnerships with lots of money tied to that. We're working currently with 3 universities, University of Kentucky, University of Louisville, and then Northern Kentucky University. And the topics are scattered, but it's children's health, smoking, opioid use, substance use, diabetes, value-based care, so a number of different things that we're working on. The submissions just came in for the next round of university partnerships, and there were 24 submissions, and we've added an extra university. So Western Kentucky University also made submissions, so we're working through those. And part of that is it's still using state data to look at things inside the state. So Academy Health came up with the State and University Partnership Learning Community, or Learning Network, where you get together with other states and they work collaboratively to support evidence-based policy and practice, focusing on healthcare, improving services, things like that. So not everything that you're doing, not every state university partnership is part of Supplin or part of a learning network, but a lot of ours are. And so we're helping to learn from other people and what we're doing. And it's just providing collaboration. And that's really what it's all about. So the part of Supplin is the Medicaid Outcome Distributed Research Network, or MODERN, and that is helping states use their data, keep the data inside their state, so you don't have the security concerns, but you can cross state lines to analyze data. So different states come together, they're pulling the same metrics, and you're able to better compare Medicaid programs across state lines, which is the whole point. We are part of the first modern project, which is concerning opiate use disorders. And over time, more states have joined the project. And Ohio is part. There we go. Ohio is part of this partnership as well. And it's really trying to organize things so we can compare data across state lines. Interestingly, the states that are part of this project account for about 21% of nationwide Medicaid enrollees. So looking at 17 or 15 different measures, also looking at the policies in each state, the services in each state, what's available for treatment, and what are some of the overdose outcomes, and then linking those claims to vital statistics. And then you can try and look at some almost predictive things with that data set. So going back to this slide from beginning, and picking out the drug deaths, we ranked 47% there. Really, the overall in the United States, that has increased steadily over the past 20 years. And in 2017, there were 70,000 overdose deaths, mostly due to opioids. National age-adjusted rate was 21.7, and in Kentucky it's 37, in Ohio it's 46. So that's a lot. That's a lot of people. Looking at the map of the nation, this is the highest, the dark blue is the highest rates. So can anybody tell me which state is the lowest? Close. It's actually Nebraska. And what about the highest? Yeah, so West Virginia is at 57, and Nebraska is at 8. So, and the overdoses are increasing for males as well as females. So which age group has the highest rate? 18 to 25. 45, 54, 18, 25. 25, well, this was kind of a trick question because almost everything you say is going to be right, except for the 18 to 24. So, well, it's going up everywhere, even in over 65. But the age groups that it's going up the highest is actually probably everybody in this room. So it's not really who you think of as being at risk for that. So what does Kentucky need to address the problem? Do we need more access to treatment providers or facilities, medications, peer support? What do we need? Well, we need the data to find out what we really need to work on. And then you need to follow that data to know if what we're working on, the services we're providing, is actually helping. So I look back, and 2 years ago when this program, this forum happened, the Medicaid medical director presented at that time. And at that time, Kentucky was a lot different. Since then, just 2 years ago, we do have an 1115 demonstration waiver for substance use that was approved. We've added methadone to our approved drug list. We've removed the barrier of needing a prior authorization for many medications. We have increased significantly the number of providers that can prescribe treatment for opiate use disorders. We've added care coordination to facilities. We've also added peer support specialists in ERs to do bridge clinics. So these are all the things we've done in the last 2 years. So when we look at the rate of opioid prescriptions over enrollees, and if you look down here, this is 2016, 2017, this second quarter of 2019. We've gone down significantly. So we're making some headway with whatever we're doing. When you're looking at the medications for opiate use disorders as well as medication-assisted treatment, we have that going up. So many more people are in treatment and receiving medications for treatment. this down here is looking at our different districts. We have 120 counties in Kentucky, so we divide them up into different area districts. And so this one is Bluegrass, this one's Big Sandy, this one's Cumberland Valley, the gray one is Kentucky River. And so when you look, that's Bluegrass, Kentucky River, Big Sandy. So it's this area where we're getting more and more people into services. But that was too many lines. So now we can divide it by managed care organization and fee for service. So when looking at who's in treatment, it's also gone up for each, or going up for each managed care company, right here. When looking at different types of treatment, residential treatment, you can see we've really gone up with who is in our residential treatment over the last couple of years, and that's increased for all of the managed care companies as well. Intensive outpatient, the same way. You can look at the number of individuals, the costs, and which managed care company or ad district that the patients are living in. So really, we're trying to look at these dashboards to monitor how we're doing and what to do next. So in the future, we have our state Medicaid and child welfare data linkages, outcomes, research that's going to happen, linking data between the child welfare division into the Medicaid division, which is a really hard thing to do. We're developing infrastructure for that data linkage and a roadmap for other states to link it on their own. Some of the things that are coming out of the state university partnerships are some predictive studies predicting who's at risk for a second overdose or who's at risk for readmission following a myocardial infarction. So really trying to use that data to help predict what's going to happen and help our beneficiaries. And then trying to incorporate some social determinants of health into the Medicaid data, not just a zip code, but looking at education, employment outcomes, looking at involvement in the justice system, looking at services that are available when people get out of the justice system, not just dropping them. So these are just some of the things we talked about. Do you guys have any questions?